Atualmente é o enfermeiro-chefe e chefe da 44ª Brigada Médica de Operações Clínicas em Fort Bragg. Ostenta diversas condecorações e distintivos, é casado e tem 7 filhos. Colonel Sir, I just gave a brief presentation of your resume, your extensive resume, and now I shall pass on the transmission to you. Good presentation. The stage is yours. Thank you.
Thank you. First of all, I appreciate the opportunity to speak to you all today. Here as we get remnants of a storm, I'm hoping that the internet from the hurricane stays where it needs to stay. So the first thing is a disclaimer that what I will talk to you about today is not necessarily the views of the Department of Defense, the Army Medical Department, or the brigade which I am attached. As we work through the information, I have no financial interests in anything that I should mention, and I disclose that I have no affiliations with any companies or products that I may mention during my discussion. I'll begin with, the first slide is a picture where, as my unit was designated to provide support to the northeastern United States of America in COVID-19 response as an operational medical brigade. With that came a very hasty departure. Within 24 hours of notification, we were conducting our movement to from North Carolina to New York City. And of course, it attracts the attention of the media. So with nursing personnel and how we conduct our business on a daily basis, patient interactions, staff interactions, I think it's important to understand that as we train our junior officers to move along to become senior officers, we have to create those moments that let them know that they may be in front of a camera and a microphone, and that they have to conduct themselves in a way that is representative of the organization, but at the same time provides the information that the public would want to know in managing those expectations of both the organization that you work for in the military and also the public that you serve in that regard. And I don't think as we grow our officers in our nurse corps that we put an emphasis on that as often as we can. So what I'll talk to you today about briefly is, again, the importance of messaging. And that messaging takes on many forms and moves up and down in lines of communication in the operational setting. And what made this unique as far as an operational deployment is we moved our forces into civilian institutions in order to provide care to patients that had overwhelmed their system, much different than what we would normally do when we just move our forces out in support of a combat element. I'll talk a little bit about what medical forces that we used. One moment, please. I will talk a little bit about what medical forces we used and why there was a difference in the way that we perceived our military operations moving forward. Talk very specifically about some measures in force health protection and choices that I made out of clinical operations in order to preserve the force. I'll talk to you briefly about some models of care that we used in implementation, and I'm going to talk a little bit about the effects of pandemic on caregivers, much different than what we would normally see in caregiver compassion fatigue from battlefield and combat injuries. So when talking about, the overview of what is it that I need to worry about as a chief of clinical operations and the chief nurse within my brigade, we had roughly 3,000 medical personnel involved in healthcare operations across 5 states. Largely what you may have seen in the media was a focus and a concentration within the city of New York. So things that I'm really responsible for and things we need to consider as we approach a civilian interaction and our military functionality is they don't necessarily lay each other very, very well. The way that we employ forces for combat is not in line with what we were necessarily asked to do. So primary role is to advise my commanders at every level about the implications of medical requirements in treating patients with COVID. And then that understanding of that medical treatment from the directorship of clinical operations down through my physician support lanes and my nursing support lanes to include hospitalization. That hospitalization occurred in multiple areas, and I'll talk a little bit about that as it pertains to the models of care that could be implemented. The preventative medicine services and their force health protection are extremely important because we want to protect our providers, obviously, from contracting COVID, and then find adequate means to look at what guidelines were being placed by the Centers for Disease Control, the World Health Organization, to return those individuals back to being caregivers as early as we possibly could. And you see that I've highlighted combat operational stress control. Within the realm of combat operational stress control, I had a myriad of elements that were able to move throughout the 5-state area to provide direct support to those individuals who were at the bedside caring for patients, and sort of cover that much in the same manner as we would in battlefield circulation for combat operational stress control. But I think we're going to find that there's even more fallout and after effect from exposure to what people saw when they were providing care. My Portuguese ability to read is almost none, but I saw that we've already talked about logistics and the requirements for that. So I will not spend a lot of time on that, but understanding that some of the logistical items were not necessarily available. And when you look at an event such as this, you call a pandemic by what it is by definition, but then the disease process itself specifically dictates or indicates what logistical items, what pharmaceuticals you actually need. And so for this being a primary respiratory disease, it would be much different than treating a disease that created a requirement for such as a cholera outbreak, a requirement for other types of medications. So we found very early on that access to paralytics, sedatives, and medications to provide comfort to patients were difficult to obtain. And that's something to consider moving forward if we were to have an event like this again, specifically as we move into influenza season, where it's going to be very difficult to ascertain whether or not somebody is presenting with a respiratory illness that is influenza or respiratory condition, which is, SARS-CoV related. And that also moves into the laboratory services, the medical laboratory services, and that became quite the undertaking at every level, and we can still see that. Yesterday, I received a brief where there's where the folks in the research department at the local hospital had reviewed over 1,000 peer-reviewed journal articles that had to do with COVID assays, COVID lab values, so on and so forth. So there's really such a volume of information to keep up with it would be almost insurmountable for the individual practitioner. So trying to find ways to filter that down within your medical organizations and deliver the so what to those individuals so that they can provide care and not be concerned with filtering through mounds of information. Things I didn't need to worry about during this was my dental services, veterinary services, nor is there a place for politics in any of these responses. I had a very, very small team to manage 3,000 people, and they're there to the left. And we had the requirement to provide that array of medical, nursing, ancillary support services in that wide geographic area, largely within organizations that we'd never been involved with before. Briefly, I won't go into this in great detail, but the creation of this was intended to try to look at our medical forces and find a way to be very precise about what type of force we arrayed where. And in order to do this, as we move into the models after this, we had to have very, very good data about the facilities that we were to support and the geographical areas that we were to support to understand where were their shortcomings. Were there shortcomings largely in a logistic issue, but they had personnel available? Was there were they short critical care physicians? Were they short critical care nurses? So as we looked at each of those areas, we came up with a manner in which we could create sort of insertion packages, for lack of a better term, that could go directly into those facilities, and those that it is by the type of provider. So you would have a critical care physician with a critical care nurse with a respiratory therapist, plus or minus any ancillary staff that would move into an intensive care unit. And we can literally identify those personnel by job specifically, and then detail them to that area, and then provide the command and control, the oversight, the communication, to make sure that they are moving in and out of the hospital every day. They're being checked every day for symptoms of COVID, and they're staying in the fight. And then in the event that we had infections arise at any area, that we knew exactly what we needed to move into that area to replace the capability or the capacity that was lost. The trick on this that we saw within the institutions that we supported, and also within our own medical personnel and nursing personnel, was a really good understanding that for the most part, when people go to work every day in a civilian medical treatment facility, they do a specific job, and they get very comfortable with that job, and they don't necessarily expand their role or have an intent to expand their role or challenge themselves to move in and out of different care areas within an institution. And there's a number of reasons we do that, everything from quality and safety to just, throughputing and being facile as a medical treatment facility. But in the event of the pandemic, such as we had, it became very, very important for the nurse that maybe works in the clinic and does very, very little in the way of direct patient care to then be able to provide care and routine care in a ward setting. And that ward nurse, who normally provides routine rounding on patients, treatment for lower acuity patients, to be able to move into the step down arena and provide care there. And then that nurse that would work in the step down area move swiftly into the intensive care area. And so it really created a requirement for, and again, I saw some indications that you've already spoken about, the requirement to train and train folks up on understanding different elements of elevated medical care, that of respiratory treatment, ambu bag use, that sort of thing. So we work with the hospitals and their education departments to sort of identify members that we had that were in uniform, that were very skilled in teaching and were qualified to sort of create those education training platforms to provide a baseline update to the type of care that the individual was expected to do when they came back to work. And at the same time, in the background, we were gathering all of the information that we could on COVID treatment, effective treatments, proning protocols, creating educational videos and series that went along with that, so that as nurses moved into the care area, there was sort of an assembly line of entry to the facility and integration, moving towards a progressive increase in the level of acuity and care that the nursing staff could perform in support of the patients throughout the hospital. The interesting thing about this too, as it pertained to a pandemic, and I'll make the comment here, versus a combat operation, is within a combat operation, our military medical forces are historically used to being in a support role, meaning there is a combat force in front. They are engaging an enemy, and we are to provide medical support to them should they become injured. In this case, where everybody's mind is always wrapped around that manner of deployment of operational medical forces, it was very difficult for them to understand there was no combatant force in front of my forces. My forces were the combat forces in direct contact with, COVID and the enemy. And it also really showed that when we talk battlefield care and outcomes, that we look at penetrating injuries and trauma, we are well aware that still historically disease and non-battle injury is the largest decrement to any of our military forces when deployed. It was interesting to see how little agreement I got with initially with an understanding that the service member in nursing care or physician care or ancillary care that contracts COVID during this event has received, quote unquote, the battlefield injury, not the disease and battle injury, because of the nature of what we were doing. So it really put a strain on those folks that normally set out to do medical planning within this environment to understand this effort, and that the medical force and the nursing force was the main effort. And I strongly argued that the nursing force by far was the main effort and represented what we would call the center of gravity in operational planning, because without that bedside nursing support directed to the patients that were in the most critical need moving downward, outcomes could not be achieved. So I'll talk briefly about this, and I see as I read back over it that I put some potential acronyms on there. So when you see the term BSI, that's a base support installation, or where your military person may come from. The forces that I had available to me in nursing and physician care were arrayed from our active forces, our reserve forces, but we're also members of the Air Force, the Navy, and the Army. So I had a joint multi-compo force. So folks, quote unquote, that had never worked together before in any real realm, now placed into medical treatment facilities that they may or may not have ever seen or had experience with. So what we found was in the different options, the first option was to just embed personnel, understanding that the facilities that we were going to support largely had the infrastructure that they needed. There was, with this pandemic, there was not a preceding disaster or a concomitant disaster that disrupted infrastructure, power, and those things. But those are considerations as I'm talking to you today, and the remnants of this hurricane move in this direction, and facilities go off and on generator power. Those individuals that are along the Gulf Coast of the United States of America, with rescue efforts and cleanup and power issues and those sort of things, are now at a higher risk for an insurgence of COVID response in the potential face of decremented medical treatment facilities. So for planning considerations, in the embed portion, consideration of those events that precede pandemic and those events that are potentially going to occur during the pandemic that will interrupt your ability to provide the care in the manner that you are. Something as simple as keeping the power on to run the generators. What happens when that goes away right now in Alabama, United States of America, to go to backup generator power? In the meantime, how does that create issues with oxygen delivery in your facility, and so on and so forth? So all those considerations. So under embed, we relied heavily on the infrastructure of the facilities that we're being asked to support. And we provided strictly staff augmentation and personal augmentation, and move them directly from their homes into the medical treatment facilities for a rapid onboarding and orientation, and then put them to work. And initially, it was where the facility placed the providers and the nurses where they needed them. So we met with them briefly, and they were placed into care areas and 100% mixed in with the staff that was there. Obviously, the strengths of this is that you can quickly bring help to the fight. You have to have that leadership exist in that facility to begin with. Not all medical treatment facilities are equal. Not all leaders in medical treatment facilities are equal. So it was very obvious to me in some cases where the internal leadership within the Department of Nursing in one facility may differ from the one 5 miles down the street as far as their ability to understand their organization and its requirements. So a lot of times that becomes a point of conversation back and forth as you help to aid or guide that entity to the correct placement of your personnel based on feedback from your subordinate nursing leaders as they engage and you conduct those daily AARs or have the availability for them to produce feedback and push it towards you for changes in your operational setting. The weakness is that, if they ask for the wrong thing.
I would like to ask you to step up the presentation, please, due to the schedule. Thank you.
Yes, sir. Thank you. Moving very, very quickly then through this piece here, to extend a facility was then to go into a facility with known infrastructure where they may have closed off a ward or a wing in a previous renovation and reopen that area, and then 100% of the care was delivered by the military providers in that area with support by the facility. And then the last, your best example of that is the Javits Medical Center in New York City. This is by far the most inefficient model to create a fully staffed hospital outside of a hospital center. So that one is the one that it would be your sort of last ditch effort towards trying to provide relief for the facilities. So moving really to the end and trying to, summarize very, very briefly for you impacts. I think for nursing personnel, in the area that we were involved and the number of patients that our nursing staff was involved with that met with negative patient outcomes, a lot of our younger nurses, military, and a lot of the civilian nurses as well had never seen or been exposed to such a level of loss. And when you combine that with the fact that facilities really weren't aware of a way to provide family members access to their loved ones, it created a very, very abrupt chasm in the grief process for everyone involved. So with that, there's a known behavioral health impact. With that, a known lasting behavioral health impact to those families that have lost loved ones that had no way to close with them. They went into the hospital and they never saw them again. So it's important to consider as we move forward in pandemic operations to find ways such as this to connect. So before we were able to finish, we found ways to connect patients via telecommunications with their families. And we also had ways for our staff and our nursing staff to connect with behavioral health providers so that they could decompress and vent to help to manage the emotions of those things going on. And again, talking briefly about this pandemic operations for military personnel, it does not mimic what we do as far as battlefield operational care. The force health protection, I recommend that, again, that we keep very, very strict entry and exit criteria to each of the care areas and operational centers as you continue to train and provide care to patients to prevent transmission to those caregivers. Our overall transmission rate during this operation for the 3,000 personnel that we had was 0.6%. So we were very aggressive in preventing transmission. Talk to you briefly about those models of care, and again, an emphasis on those individuals that may be and continuing to have grief from this event. With that, I will pause for any questions, and it concludes my presentation.
Ask the questions in the end of the presentations. We are still one speaker left to present, and so I thank you, and I ask you to wait a little bit to see if there's any one question.
Yes, sir. Thank you.
Vamos continuar com o último palestrante desta mesa, que será o Sr. Tenente Coronel Molina, de Espanha. Não sei se conseguimos. Tenente Coronel Molina. Buenas